you have the ability to mute yourself at your site, and that way we don't get a lot of feedback in the microphones. So if you would go ahead and mute yourself at your control panel, there's a little microphone by your name, and you can mute and unmute yourself. Or up here on the control panel, if you can see my screen, you can mute and unmute yourself. So if you could do that, and then as we get going this evening, there'll be a couple times we'll pause and answer any questions you might have, and then we'll have an opportunity at the end of the session to answer questions as well. And with that, if there aren't any questions, I'd like to go ahead and get started and welcome you to my little talk tonight. My name is Jeff Messerol, and I'm a paramedic, and I'm a clinical instructor at Spencer Hospital in Spencer, Iowa, up in the northwest corner of the state, just north of you. I actually live in Spirit Lake, Iowa, and drive to Spencer to work, and that's where I'm at this evening. I'd like to again welcome you all to the class, and it's on diabetes, and I think initially we should probably look at the prevalence of diabetes, and you all know that it's on the rise, but it's interesting to note that since 1990, those people who have been diagnosed with diabetes has tripled, and you can see the curve here sharply rising. And in all estimates, as far as 2011 through 2013 goes, those numbers continue to climb. It's estimated that 1/3 of all Americans are pre-diabetic, and about 25 million Americans have been diagnosed with diabetes. If we look at the United States and the location of where those, or the highest percentage of diabetics live, you can see here in Iowa that we average somewhere between 6.4 and 7.5% of our population is diabetic. But if you look down here in the South, the CDC has given this part of the country the name the diabetic belt. It includes about 655 counties across 15 different states. And there's a wide variety of reasons for diabetes being so high in that particular area. Much has to do with diet and race and weight. If we look at Iowa specifically by age categories based on tens of thousands of people, the 45 to 64-year-old group has seen a really sharp increase in the number of those aged people being diagnosed with diabetes. Most of the other age groups have maintained relatively consistent lines here, but the 45 to 64-year-olds has really increased, and that might be because of the baby boomers. We have more and more 45 to 64-year-olds than we have in years past. Now, you really can't talk about diabetes, in my opinion, without talking about sugar and high fructose corn syrup. Diabetes is a disease that has everything to do with sugar. So I'm going to take this a little different direction than most diabetic talks. And I'm going to start first talking a little bit about sugar and high fructose corn syrup before I actually get into our talk on diabetes. You know, in the 1890s, the average American consumed about 4 ounces of sugar. In fact, sugar was essentially more valuable than gold in some cases. And before the sugar was rationed in World War II, the average American was getting about 15 pounds of sugar a year. But after the sugar ration was lifted, after World War II, sugar consumption rose by 30% in the 80s, and they were getting somewhere in the neighborhood of 75 pounds of sugar per person per year. By the 1990s, they were getting 152 pounds of sugar per person per year. And in 2011, it was estimated that the average American consumed 200 pounds of sugar a year. Now, the problem with that is that your body was never, ever designed to consume that much sugar. We know that sugar is important for metabolism, and that with sugar and oxygen, we create energy to fuel our cells. But if we consume far more sugar than we need, that sugar is deposited into the cells. That sugar is converted into fat. And so we can see, just looking at raw numbers here, that in addition to consuming more sugar every year, Americans themselves are getting larger just as a result of that. You know, have you ever asked yourself just how much sugar are you getting in your current diet? And if you look at the American Heart Association, they recommend that a woman should get 6.5 teaspoons a day of sugar, and a man should get about 9.5 teaspoons of sugar a day. And if you want to know how much sugar is that, because sugar is typically measured in grams. If you look at the labels on your candy bars, if you look at the labels on your food, the sugar content is listed in grams. So 4 grams of sugar equals 1 teaspoon of sugar. 4 grams equals 1 teaspoon. And, you know, let's look at some common things that we consume in our daily diet. And we're going to start first with soda. A can of regular soda, and I underline can here because I really don't know anybody who drinks cans of soda. They're usually drinking a 20-ounce container of soda, a Big Gulp, or a 44-ounce you know, soda fountain pop. And if you look at that, a can of soda has 39 grams of sugar in it, and that's equivalent to eating 2 Hershey candy bars. Now, I don't know about you, but I wouldn't sit down at any one time and consume 2 full-size Hershey candy bars. But at one point in time, I used to drink 6 or 8 sodas a day. And as a result, I was getting far more sugar than I actually needed. You wouldn't think there'd be sugar in tomato soup, but in 1 can of tomato soup, there is 12 grams of sugar per serving. And there's 2.5 servings in a can of tomato soup. And I know people, or individuals, who could consume an entire can of tomato soup in one sitting, so they would be getting 30 grams, or roughly 8 teaspoons of sugar. If we look at things that we believe are healthy for us, like V8 Fusion drinks, there's 38 grams of sugar in a V8 Fusion drink. Or Slim Fast, that's got to make us slim. Well, there's 35 grams of sugar in a can of Slim Fast. Baby food. You wouldn't think there would be any sugar in baby food, but baby food contains anywhere from 9 to 12 grams of sugar, anywhere from 2 to 4 teaspoons of sugar in baby food. McDonald's hamburger. A McDonald's hamburger has 4 grams of sugar, or a teaspoon of sugar in the hamburger. And the reason that the sugar's there is that our body craves sugar, especially as we become more pre-diabetic as a result of our diets. And I'll explain that in a while. Vitamin water. That's got to be healthy for us because it says it's vitamin water. Well, it's got 8 teaspoons full of sugar in a container of vitamin water. Juicy juice. They convince us that we need to feed our children, or we make sure that our children get 100% juice. And juicy juice is one of those products that does provide 100% apple juice. But with it comes 21 grams, or 5 teaspoons of sugar. Powerade has 37 grams of sugar, not to mention the sodium. You know, if you're going to give your child, or if you yourself is going to, you know, drink a Powerade, you'd be better off eating 2 candy bars because you wouldn't get all the sodium that's associated with the Powerade drink. Fruit. People are concerned about the sugar in fruit, and fruit does have a lot of sugar. Remember that 4 grams of sugar equals a teaspoonful. And if we look at an apple or a banana, those are some of the higher, a pear, an orange, those are really high in sugar. There's a site out there with their mic open. If you could mute it, please. The issue with fruit is that if you're going to consume fruit, which is better for you than raw sugar, eat your fruit with protein or balance your fruit with protein. When you eat fruit with protein, protein releases glucagon, and glucagon counteracts insulin. So the two balance each other quite well. We also have to keep in mind portion size. Those mega muffins or those big muffins, they contain 58 grams or 14.5 teaspoons of sugar in one of the big muffins. And if you look at the serving size on a big muffin, it's typically 4 servings. Or one big cookie, that's usually 4 servings. So in addition to looking at the amount of sugar that's on a container, look at the serving size so that if you eat what's in the entire container, you know exactly how much sugar you're getting. Now the issue with sugar, besides diabetes, is there's a significant correlation between high sugar levels and not only an increase in diabetes, but an increase in heart attack and an increase in stroke. Sugar accelerates coronary artery disease or cerebrovascular disease. If you look at this blood sample here, the white segment of this blood sample is free sugar that has spun out, and the elements of the blood are here, the plasma is here, and the white section here in the middle is what we call triglycerides or free fatty sugar. That would be in somebody who has a real high triglyceride count. Now, so sugar's bad. So you think, well, I'm going to have sugar-free. Just remember that there's no free ride, and that sugar-free foods have sugar alcohols in them. Not the kind of alcohol that's going to make you a little woozy. If anything, the alcohol is going to give you some abdominal cramping and diarrhea if you eat enough of it. But sugar-free makes you obsess about sweets. Sugar-free is sweet. It makes you obsess about sweets when you have sugar-free. How about fat-free? You know, we're concerned about fat because fat-free yogurt has 47 grams of sugar in it. You know, when they take the fat out of a product, it doesn't taste very well. So in order to make it taste better, they add sugar. So your fat-free yogurts, your fat-free this, your fat-free that, yeah, the fat's been removed, but they've added sugar to make it taste well so that we'll eat it. So fat-free isn't necessarily a good dietary choice. The Institute of Medicine says we should balance our diet. We should get 45 to 65% of our diet should be carbohydrates. 25% of our diet should be sugars. 20 to 35% of our diet fats, and 10 to 35% of our diet's protein. 100% of all carbohydrates are broken down into sugar. But depending upon the complexity of the carbohydrate, the amount of energy required to break it down is worth having the carbohydrate. The darker the carbohydrate, it seems the more difficult it is to break down. As an example, carbohydrates that are white, potatoes, rice, white bread, they quickly break down into sugar, where whole wheat or wheat bread, where you can actually see the cracked pieces of wheat in it, are very harder to digest and take longer to break down into sugar. So 25% of your diet from sugar is equivalent to 400 to 500 calories of added sugar every day. And for some people, that's a meal. In one study, it was interesting that if you consume 400 calories of sugar a day, those folks had a 25% lower bone density than those who ate less sugar. So there's actually a tie between bone density and high sugar content. And the higher your sugar content, the lower your bone density. Sugar is actually an inflammatory. It can cause you to feel hungover. It can give you joint pain, cause diarrhea. It can worsen asthma, cause fatigue and irritability, and definitely weight gain and cravings for more and more sugar. 20 to 24 teaspoons of sugar, or somewhere around 6 grams of sugar, reduces the efficiency of the white blood cells by 92%, and that lasts up to 5 hours after consuming that sugary treat. So you really open yourselves up to a potential for infection when you consume lots of sugar. Now, sugar causes insulin to be released, and we'll spend some time in our talk tonight looking at what happens when we have way more sugar in our bloodstream than what we need, and how our body has to over-secrete insulin to try to get the sugar out of there. Insulin increases hunger. Insulin is a stressor on the body, and the more weight you carry, the more insulin you have to make. Insulin is dumped into your bloodstream just a few hours after you eat in response to a rise in your blood glucose. Why should we cut back on sugar? Well, it has no nutrients. It actually pulls nutrients from the body. It promotes skin aging. And again, your body was never designed to handle 200 pounds of sugar. Sugar makes you fat. It increases your risk of diabetes. It increases your risk of hypertension. It increases your risk of heart attack and stroke. Then came, as if sugar wasn't bad enough, then came high fructose corn syrup. It came out of Japan in 1966, came over to America in 1965. It was really cheap, and it was far sweeter than sugar. So high fructose corn syrup is sweeter than sugar. And if you look at what makes high fructose corn syrup, and you compare that to just regular sugar, with high fructose corn syrup, 45% is sugar and 55% is fructose, where it's a 50-50 mix with regular sugar. So it's not a big difference, but high fructose corn syrup is far sweeter and a lot less expensive to make than sugar. And fructose, high fructose corn syrup, metabolizes in a very different way than sugar does. With fructose, 100% of the metabolic metabolism of fructose lies in your liver, where with regular sugar, only 20% of metabolizing that sugar lies in your liver. So your liver really has to work hard when you consume high fructose corn syrup. Now, when you compare sugar to high fructose corn syrup, 120 calories of glucose or sugar, less than 1 calorie of that will be stored as fat. But if you take 100 calories of fructose, 40 calories of that is stored as fat. So high fructose corn syrup increases weight gain at almost a 40 times higher, faster rate than sugar does. It causes weight gain. It does not stimulate leptin, and leptin is a hormone that your body stimulates when it's full. So if you eat a lot of food that contains high fructose corn syrup, you don't get that feeling like you're full. You get lots of fructose, but you don't get that feeling that you're full. Metabolizing high fructose corn syrup in the liver creates waste products and toxins that are harmful to the rest of your body. It increases your triglycerides, and remember, triglycerides was that free soluble liquid fat that floats around in your bloodstream. It can raise your blood pressure, it makes your insulin less sensitive, and it stimulates ghrelin, and ghrelin is a hormone in your body that makes you feel hungry. So eating high fructose corn syrup actually makes you hungry. So you have to ask yourself, sugar and high fructose corn syrup, is that a friend or is that a foe? And there's a big movement to label products that contain high fructose corn syrup, or products will specify they contain no high fructose corn syrup. Okay? I'm going to pause this a moment and see if there are any questions. All right. I'm going to guess the silence means there are no questions, so we're going to go ahead and move on here and start talking about diabetes. Not sure why that won't go away. Artaeus of Cappadocia in 200 AD noticed that patients who had diabetes, of course it wasn't known as diabetes then, he just noted these patients that had to urinate a lot. And they urinated a lot and within a couple weeks were dead. So he coined the term diabetes, which is Greek, that means siphon or pass through, because people with diabetes urinated a lot. And it wasn't until centuries later that another physician added the word mellitus, because what he noted was that people with diabetes not only urinated a lot, but their urine was sweet. And he didn't taste their urine. He just knew it was sweet because of an old universal test for diabetes back then. They would take your urine and they would pour it on an anthill. If the ants rushed towards it, it was full of sugar. If the ants strayed away from it, then it was not full of sugar. So back then, they had no idea what caused this disease, diabetes mellitus. They just knew that if you had honey urine and you urinated a lot, you had this disease and for a quick death. Now move ahead centuries later, almost 1,600 years later, Paul Langerhans Okay, can you hear me now? Wave your hands. Yes. Okay. All right. Sorry about that. Not sure why that happened, but we'll keep moving on here. Can you see my screen, the PowerPoint? Yes? Because I'm not getting it to open up.
We can see the one that you had just been talking about with the diabetes mellitus.
Yeah. The guy. But I can't get the PowerPoint to come up. The whole, like it was on a big screen. Let me try here. I think Cherry has to give me control back. So I will call her real quick. I apologize for the snafu. One minute. She had given me control of the screen, but evidently when I got booted off and came back on, she has to re-give me control, I'm going to guess. So I will call her and have her do that. Hello? Yeah, I got kicked off, and then I came back on, but it won't give me control of my screen. You have to give me control of the screen. Okay. Let me make sure that I don't see my screen. There we go. Okay, can you see it okay? Can you hear it okay?
Yep.
Can you hear it? Okay. Yeah, okay. All right,
You can hear it, Danbury.
I'm going to keep moving. Yep. All right, so I really apologize for that. I'm not sure why it kicked me off, but we'll keep moving on here, and then maybe we'll save our questions till the end. You know, with diabetes, we had talked about the original folks that named the disease, and in 1869, how Paul Langerhans identified the beta cells in the pancreas, and that's where insulin is made and secreted from the beta cells in the pancreas, but he didn't know that. He just knew that if you removed the pancreas of a dog, that the dog peed uncontrollably. So they still hadn't linked diabetes to the cause. They knew that if you had the disease, even in 1869, that you died a horrible death. Later in 1889, these other two gentlemen identified that the pancreas secreted this solution or this substance that must regulate blood sugar. They didn't know what it was, and they did link diabetes to a disease of the pancreas. So we're getting closer here, but it wasn't until 1921 that a couple gentlemen from Canada extracted the fluid from the islet of Langerhans, where the beta cells in the pancreas are, and they took that fluid and injected it into a dog who had diabetes. The dog got better, the blood sugar lowered, and they later added another gentleman who began using pancreatic fluid from cattle, and then they called this fluid insulin. And it wasn't until 1923 that they actually tried it on a human, and it was a 14-year-old boy who had been diagnosed with diabetes and was near death. And he was the first one to receive this insulin. And it was a success. His blood glucose got lower, he got better, and by taking regular injections of this insulin, he was able to regulate his blood glucose. So some would argue that insulin is probably the greatest discovery in medicine of all time. Because prior to 1923, if you were diagnosed with diabetes, you were guaranteed a certain death, an ugly death. So in summary of the pancreas as the organ that is affected by diabetes, these islets of Langerhans, these beta cells located in the pancreas, is where insulin is secreted. And it's secreted into the bloodstream in response to food that's taken into the stomach. The alpha cells of the pancreas stimulate another hormone called glucagon. And glucagon stimulates the breakdown of glycogen. And glycogen is sugar stores that are in your liver. When you consume more sugar than you need, some of it is stored by the liver in the form of glycogen to be used when you exercise or to be used when you are really stressed and you need that additional sugar for energy. When glucagon is secreted by the pancreas, that promotes glycogen to be converted into sugar and your blood sugar rises. It occurs mainly in the liver. The beta cells of the pancreas, that's what secretes insulin. And insulin works in the reverse of glucagon. Insulin lowers your blood glucose level by taking the sugar out of your blood and moving it into the cell. Okay? We all know that cells have to have sugar in order to metabolize. And the only way that sugar gets from your bloodstream into your cell is with insulin. So you have to secrete enough insulin in order to meet the demands of the cell so that the insulin can move the sugar into your cells. When you don't have enough insulin, or the insulin that you have isn't very effective, your cells will make energy. They will metabolize without sugar. And what they'll do is they'll burn fat. And by burning fat, the byproduct of that is acid or ketones. And the more ketones or the more fat burning that you have going on, the more acid is dropped into your bloodstream. And that's hard on your kidneys, and that's hard on your liver and hard on your other vital organs. You may be familiar with the Mayo Clinic diet. It was a way that somebody could drop a tremendous amount of weight really quick. And what they did was they didn't consume any carbohydrates. And by not consuming carbohydrates, their blood glucose levels got dangerously low. And instead of making energy with oxygen and sugar, the body would make energy by burning fat stores. So you dropped a lot of weight fast, but it's really hard on your kidneys and your liver and your other vital organs because of all the acid that's dropped into your bloodstream. Okay, so fat metabolism, while I certainly could use 20 or 30 pounds off, it's not a good thing. It is hard on the body. And here's another way to illustrate it. We normally have a blood glucose level. We normally have 80 to 100 milligrams per deciliter of blood. So if we were to measure our blood glucose, normal is somewhere around 80 to 100. Now let's say you drink that can of pop. And when you drink that can of pop, your blood sugar rises. Your blood glucose rises. In response to a rise to your blood glucose, your pancreas secretes insulin. And the insulin is indicated here by these little green arrows. Now what insulin does is insulin moves that sugar out of your bloodstream and into the cell to be used for energy or to be stored later to be used for energy. When all that excess sugar is moved into the cell by insulin, then your blood sugar returns to normal, 80 to 100. But what happens when you consume more sugar than your cells can hold? That's called insulin resistance. When your cells become full of sugar and you continue to consume more sugar than you can use, your body secretes lots of insulin to get rid of this extra excess sugar, but there's nowhere for it to go. And the cells resist your insulin, and you become pre-diabetic. Again, it's estimated that 33% of all Americans are pre-diabetic. As your blood sugar continues to increase in that neighborhood of 100 to 125, you're pre-diabetic. With blood sugars greater than 126, a fasting blood sugar greater than 126, you're diabetic. So we can use fasting blood sugars, particularly several in a row, to determine whether or not we have diabetes. We can use fasting blood sugars, and if we have several in a row that are more than 100 but less than 126, we're pre-diabetic. Now, just reducing your weight 7 to 10% and exercising at least 150 minutes a week, you'll ward off getting diabetes. Doesn't matter how big you are, just reducing your weight by 10% and adding exercise along with some diet modification, you'll ward off diabetes. But if you don't, then you will become diabetic. And remember, diabetes increases your risk of heart attack, it increases your risk of stroke, it causes high blood pressure, causes high cholesterol, because sugar that is not consumed and not used is converted into fat, and that fat is called triglycerides, and triglycerides plug your vessels. Diabetes is the leading cause of blindness. Diabetes is the leading cause of end-stage kidney failure. You are 2 to 4 times more likely to have a stroke or a heart attack if you're diabetic. Diabetic neuropathy is the leading cause of non-traumatic lower limb amputations. So it's a problem. Diabetes is a problem. Normal blood glucose is 80 to 90. Some would say normal is 70 to 110. If your blood glucose is less than 70 or less than 60 in some articles, then you're hypoglycemic. You don't have enough blood sugar. If your blood glucose is greater than 110, you're fasting. In other words, you've had nothing to eat or drink after midnight, and you take your blood sugar in the morning. If your blood glucose is greater than 110, then you're hyperglycemic. You have too much sugar in your bloodstream. We're going to look a little bit later about the role of the pancreas in diabetes and the liver and the kidneys, as they all play a really important role during diabetes to keep your body as normal as it can be. We're also going to look at osmotic diuresis, or what your body does to get rid of sugar when your blood sugar rises. Diabetes, by definition, is defined as having a fasting blood glucose of 126 or greater on 2 separate occasions. If diabetes symptoms exist and you randomly take your blood glucose at any time of the day and it's greater than 200 on separate occasions, you have diabetes. Now, what's being used more frequently is what's called a hemoglobin A1C. And a hemoglobin A1C measures or estimates the average amount of blood glucose that you have over a 3-month period. And it does this because sugar is sticky. And when you have sugar in your bloodstream, it has a tendency to stick to the hemoglobin, much like oxygen sticks to the hemoglobin. And these red cells live about 3 months. So by measuring the hemoglobin A1C, they can get an idea of what your average blood glucose is over a 3-month period. And that's probably a better measurement than just a random blood sugar, because it really depends on what you eat and your exercise and everything else, whether or not your sugar is going to be high. People's blood glucoses fluctuate tremendously throughout a period of 1 day. So diabetics will often look at their hemoglobin A1C in order to know whether or not they're doing good with their compliancy, or they're doing good in managing their disease. You know, a hemoglobin A1C of 6 or less in a diabetic is super. If you can keep it under 7, you know, if you keep your A1C under 7, that means your average blood glucose is 170. That's still pretty high, but you know, it's not up there where these sort of sugars are related to kidney failure and blindness and all those other things associated with diabetes. Now, there are 2 types of diabetes. There's type 1 diabetes. It's also, or it had been called, juvenile diabetes, because you got type 1 diabetes when you were a kid. And type 1 diabetes is characterized by little or no production of insulin. So type 1 diabetes is also known as insulin-dependent diabetes mellitus, or IDDM. So if somebody has a medic alert bracelet, it often will say diabetes, but it may define the type as IDDM, insulin-dependent diabetic mellitus, so you know they take insulin. And this type of diabetes is closely related to heredity. There's a concept or a belief that this type of diabetes is an autoimmune disease, much like lupus, where your body destroys the beta cells of the pancreas. Not sure why, but your body destroys the beta cells of your pancreas, and your pancreas doesn't secrete insulin. So type 1 diabetes, onset as a child, is usually no fault of your own. The diagnosis is high blood sugar, because if I'm not able to produce insulin, then the sugar in my bloodstream cannot get into the cells, and it rises and rises and rises until it causes diabetic ketoacidosis, and then I get diagnosed with diabetes. And the treatment for type 1 diabetes is to inject insulin. By injecting insulin, I supply that missing hormone that helps move the sugar out of my blood and into the cell. Type 1 diabetics are also most prone to hypoglycemia, or low blood sugars, because as they learn what type of insulin and how much insulin to inject based on how much they eat and what they eat in a day, regulating that can be really tricky, and they are more prone to overshoot too much insulin, not enough food, and end up with low blood glucoses. And as EMTs in Iowa, you can, with medical director approval, use a glucometer and determine whether or not a person with altered mental status or with a history of diabetes has a low or high blood glucose. But type 1 diabetic emergencies are usually related to hypoglycemia, or low blood sugar. Type 2 diabetes was called adult onset diabetes, and this is a type of diabetes that can be managed without insulin. It can be managed with diet and exercise. It may take some oral medications to help lower the blood glucose as well. The abbreviation for this is NIDDM, non-insulin dependent diabetes mellitus. Now, it can be hereditary if you come from a long line of diabetics. Certainly as you age and get older, you're at increased risk of developing type 2 diabetes. But most all type 2 diabetes in the United States, 80 to 90% of type 2 diabetes is caused by obesity, is caused by too many carbs and too much sugar. Type 2 diabetes accounts for 90% of all diagnosed diabetic patients. We'll talk about diabetic ketoacidosis, which can occur in type 1 and type 2 diabetics. We'll also talk about a condition known as hyperglycemic hyperosmolar non-ketonic acidosis, which is another condition that can occur in diabetics. In both those situations, blood sugar is really high. There's a new type of diabetes on the horizon, if you will. I know that this is something that that just of late has been described. They call it diabetes type 1.5, and it's actually a combination of the two. Your pancreas secretes insulin, but it's not very good, and your cells are resistant to the insulin that you're secreting. So these folks with type 1.5 diabetes may, in addition to oral medications, have to give themselves insulin injections too. Now, the type of diabetic emergencies, because this is a disease involving blood sugar, you're going to deal with patients who are hypoglycemic or who have low blood sugar. And we call that insulin shock, because low blood sugar is almost always caused by taking insulin. Hyperglycemia in diabetic patients, or high blood sugar, we call that diabetic coma. And if left to progress, it can evolve into diabetic ketoacidosis or this hyperglycemic hyperosmolar non-ketonic coma, or HHNC. And we'll look at these two conditions here, focus mostly on high blood sugars tonight. With low blood sugar, insulin shock. We call it insulin shock because insulin is the culprit here, and the patient looks like they're in shock. It comes on suddenly, really quick, within minutes. It comes in diabetic patients who take their insulin but don't eat. So if I take my insulin and I don't follow that up with food, the sugar that I have in my blood is moved into the cell and my blood glucose drops suddenly. It happens in type 1 diabetics who take their insulin but eat the wrong type of food. They don't get enough glucose, or they don't get enough carbohydrates. If they eat primarily fat or protein, like bacon and eggs, there's a lot of fat and protein in those, and there's not much for carbohydrates and not much for sugar. If they take their insulin and then they work a lot harder and they burn more sugar than they normally do, again, they present like they're in shock. Comes on suddenly. Their heart rate is rapid. Initially, their blood pressure is elevated. Their pulse is bounding. They have cool, clammy skin. Their blood sugar, if you measure it, is less than 60. And it will lead to sudden altered level of consciousness. Hyperglycemia, or high blood glucose, we call that diabetic coma, and it can progress into diabetic ketoacidosis, as we'll talk about. Hyperglycemia occurs gradually over days, maybe 3 or 5 days. You see this in undiagnosed diabetics. In fact, that's how most diabetics are diagnosed: high blood glucose or hyperglycemia. You'll also see it in diabetics who are non-compliant. They don't take their oral meds to lower their blood glucose, or they don't take their insulin to lower their blood glucose. And as a result, their blood glucose gets really high. In a patient who has a sudden acute illness with a fever or a flu, illness is a stress to your body. And anytime your body is stressed, you release stress hormones that cause your blood glucose to rise. It leads to dehydration and acidosis, and we'll explain how that happens. In an earlier slide, I mentioned something about osmotic diuresis. And when your blood sugar starts to rise, your kidneys sense this rise in blood sugar and attempt to eliminate the sugar out of your bloodstream or filter the sugar out of your bloodstream by making large amounts of urine filled with this sugar. So you start spilling sugar or start spilling sugar out of your urine. So you urinate a lot when your blood sugar is high. And as a result, if you don't replace that with volume or you don't replace that with fluid, you can easily become dehydrated. Now, if you're not getting sugar from the bloodstream into the cells will begin to metabolize fat. And the byproduct of ketosis, or fat metabolism, are acids. So the more fat metabolism occurs, the more acids are dumped into your bloodstream, and the lower your pH becomes. You end up getting acidic. Now, the signs and symptoms of hyperglycemia, or high blood sugar, remember it comes on gradually. Here it says over about 2 days, anywhere from 2 to 5 days. It takes that long for it to come on. Patients with hyperglycemia or high blood sugar get the polys. They get polydyspia, which means they're constantly thirsty because they're peeing a lot. They get polyphagia, which means they're constantly hungry because their cells aren't getting energy, and the cells are telling the body, feed me, feed me, feed me. So they're starved. And as a result, they have a tendency to look at or look towards comfort foods, potato chips, candy bars, sodas, things that they don't have to do a lot of prep with, things that they can easily consume. And as a result, that drives their blood glucose up even higher. And they get polyuria. They pee a lot because they're making lots and lots of urine. The kidneys are making lots and lots of urine in order to get rid of that blood sugar. Now, as they metabolize fat, and if they get enough of this fatty acid in their bloodstream, enough of these ketones give off an odor like acetone, like non-scented fingernail polish remover. Some describe it as a sweet, fruity odor on their breath, kind of like juicy fruit gum. The problem with the sweet, fruity odor on the breath, the problem with that is that about 65% of the people can't smell that. So if you smell that, that might be a good indication that they have a high blood sugar. But you may not be able to smell it at all because you may be one of those 65%. Now, to get rid of. And water is H2O. H is hydrogen. And hydrogen in your body, excess hydrogen in your body, is what these acids are producing. So you breathe deep and rapid to get rid of those hydrogen ions, to get rid of that hydrogen. And that's called Kussmaul's respirations. They're not short of breath. Their pulse oximetry is 100% or 98%. Their lungs are clear. They're just breathing really deep and really rapid, and they may have a sweet, fruity odor on their breath. They're severely dehydrated. Their skin is warm and dry. If I pull it up into a tent or I pinch it up into a tent, when I let go of it, it stays tented. Their heart rate is fast, their blood pressure is low, and they eventually develop an altered mental status to the point of being in a coma. And you're in a coma with diabetic ketoacidosis, or can be in a coma with diabetic ketoacidosis, not because the brain can't get blood sugar, because there's lots of sugar in your blood. And the brain is an organ that doesn't require insulin to get sugar into itself. It'll pull sugar out of the blood if it needs it. It doesn't need insulin. All your other cells do. The issue of unconsciousness with this is your brain does not function if it's dry and it's being bathed in acid. So that's why you're unconscious. Not because your sugar's really high, but because of your high sugar, you're dehydrated and you've got a lot of acid in your blood. So that causes your altered mental status. Getting a really good history, particularly in an unresponsive person, is going to be your key that you're possibly dealing with a diabetic patient. If you have a diabetic patient with an altered mental status and they tell you that he was fine and it came on suddenly, and he's pale, cool, and clammy with a rapid bounding pulse, you know, chances are you're dealing with low blood glucose. But if they tell you he's been sick for days, he's started nesting on the couch and he's been eating all this junk food, he's been peeing a lot, he's constantly hungry and thirsty, he's breathing deep and rapid and his breath smells like acetone, then you're dealing with high blood sugar. The management of high blood sugar is to support their breathing and their airway. Only if they're in a coma. You know, if they're awake, they can manage their own airway. And if they're in a coma, supporting their airway and breathing doesn't mean give them oxygen. If they're in a coma or they're not responsive, they may be at risk of aspirating if they vomit. So putting these people in a recovery position would go a long way, so that if they did vomit, they weren't lying flat on their back, or setting them up in a semi-Fowler's at a 30 or 45 degree angle and even rolled on their side would be appropriate. We don't need to give them oxygen because breathing is not a problem for them. They're not having any trouble with oxygen. They're having trouble with really high blood sugars. You can check their pulse oximetry to make sure, but it's going to be normal. Their lungs are going to be clear. Their skin's going to be pale and dry because of the dehydration, but they won't have any signs of respiratory distress. These people need fluid. So if you're an ALS service or an advanced EMT and you can start an IV, these folks need fluid. And it may take lots of fluid with high blood glucose. They may need to have an IV established, and they may need 2 or 3 liters of fluid, at least to get them started. Now, it doesn't have to be rushed in. That liter of fluid should go in over about 30 minutes. In giving large volumes of fluid really fast, particularly in children, we can cause swelling of the brain. And we don't want to do that. So we want to give them fluid, and it may take lots, but we give it about a liter over 30 minutes. Monitor their blood pressure, their pulse, their respirations. Giving them fluid hydrates them. Giving them fluid actually lowers their blood glucose by 25%. Now, if you use your glucometer in these patients with high blood sugar, and it's saying HHH, which means it's greater than 300 or greater than 600, you know, dropping that 25% isn't going to be enough. But do, you know, understand that if I give you fluid and I hydrate you, I'm going to drop your blood sugar a little bit by 25%. And then they need insulin. and they may need potassium. So we need to get them to a hospital where they can get insulin and they can get potassium. To date, EMS services are not allowed to give insulin in the field. Hyperglycemic, hyperosmolar, non-ketonic coma. We see this in type 2 diabetics. It's often related to patients on dialysis. It's often related to type 2 diabetics with infections. And it may be related to those who are non-compliant with their medications. It results in really, really high blood glucose levels, levels of 1,000. So there's no way you could measure that on your glucometer in the field, but in the hospital they would note that their blood glucose is 1,000 milligrams per deciliter. And what happens is you secrete enough insulin that you're getting enough sugar in the cell so the cell doesn't burn fat, but you're not secreting enough insulin to get all the sugar out. And as a result, the sugar builds up and up and up over a period of about 14 days, and it has a very high mortality rate because the sugar is so high. They are so severely dehydrated by the time we get the 911 call. Their potassium is way out of whack, but they don't develop Kussmaul's breathing. They don't develop the fruity odor because they aren't burning fat. They have all the other symptoms, but they don't have the Kussmaul's breathing and don't have the sweet fruity odor. We're going to look at a couple scenarios, and then we'll stop and take questions because we'll be done. I call this one couch coma. You're paged for an emergency for an unconscious man. Upon arrival, you're led to the back bedroom where you find a man lying in feces and urine. He's unresponsive on a couch. He's breathing deep and rapid. His eyes are closed. So in class, I would ask you, what would you like to know? And I'm sure your assessment begins with scene observation. If you know this patient, they're a frequent flyer, you may know they're diabetic. But if you don't know this patient, you might have to rely on scene clues to let you know that they're a diabetic, whether it be medic alert bracelets, the presence of syringes or insulin, the presence of glucagon, the presence of a glucometer or an insulin pump, the presence of limb prosthetics or crutches. All might be indications that you're dealing with a diabetic patient. So ABCs are okay. We're going to get his vital signs. He has 101.4 temp. That tells you he's got an infection. Remember, with an infection, everybody who has an infection, their blood glucose is going to be elevated. His heart rate's 124. His respiratory rate is 32. That's pretty fast. And his pressure's 96/70, which isn't normal. So he's got a rapid heart rate. He's got a low blood pressure. He's breathing deep and rapid, and he's got a fever. He's pale, warm, and dry. His skin tense when you pinch it. Now, in the initial assessment of a patient with altered mental status, using AVPU is really the best way to assess their mentation, to assess their mental status. You know, is he alert there on the couch? Is he awake, talking to me? If not, does he respond to voice? If not, does he respond to some sort of painful stimuli? And if not, he's unresponsive. You know, doing a Glasgow coma scale, there's a place for that, but certainly this isn't one of them. I like to use the mnemonic AEIOU tips to help me remember why somebody would have an altered level of consciousness. And the A stands for maybe this guy's had a heart attack. Maybe he's intoxicated. Maybe he has anaphylaxis. Maybe he's an epileptic and he's postdictal. Maybe he's got some sort of brain infection or an electrolyte imbalance. Maybe it is a sugar issue. Maybe his sugar's too high or too low. Maybe he's overdosed on something. Maybe there's a need for oxygen and he's hypoxic, because hypoxia would cause altered mental status as well. Maybe he's in kidney failure. Maybe he's got a head injury. Maybe he's got some sort of infection like meningitis. Maybe he's been poisoned. Maybe his blood pressure is too low or too high. Maybe he's had a stroke. And maybe he's had a seizure, because not all seizures are epileptic. So these would be some things you could look for in a person who has an altered mental state. We also look at OPQRST and sample. And I add an N to my OPQRST. N is this normal? Is this normal for him to be this way? And we don't know if this is normal, but we're going to guess it's not normal for him to be covered in feces and urine lying on the couch. We know that he's been on the couch for a while. The TV is on. He's been nesting. There's alcohol, beer cans, and food wrappers and all kinds of things around the couch. We don't know what makes this better or worse. We don't know the quality of this problem, but he does respond purposefully to pain. In other words, he withdraws. He tries to get out of the way when we apply some painful stimulus. We don't know if this radiates. We don't know if he hurts. We just know he has a severe medical emergency, and his neighbor saw him 2 days ago. He's got no medical alert tag or meds. And my sample, this is what I see. He's warm and dry, unresponsive, dehydrated, dry feces, a strong, sweet odor to his breath, Kussmaul's breathing. His foot's kind of necrotic and black. Don't know if he's allergic to allergies. I don't find any meds. He does have some surgical scars. There's a lot of dried, crusted food around. And what led to this, I'm not sure. So putting this together, does he have any other signs and symptoms associated with a diabetic emergency is a question I might ask myself as well. If I check his blood glucose and it tells me it's HHH, or if my blood glucose is able to read it and it tells me it's 800, then I know my problem is, if he's never been diagnosed with diabetes, he's going to get the diagnosis now. Or he has diabetes, and because he's not been compliant, because he's been ill, his blood glucose has gotten out of control, and he's suffering from hyperglycemia. Whether or not he has diabetic ketoacidosis, in other words, he's been metabolizing lots of fat, I don't know that for sure. There are lab tests that have to be done to confirm that. But I do know his blood glucose is really high. Diabetic ketoacidosis is often referred to as famine in the midst of plenty. Your cells are starving for sugar, but you've got no insulin to get it in there. In order to have diabetic ketoacidosis, you got to have some blood tests. You got to know what your blood glucose is, and a blood glucose greater than 200 has to be present. You got to have metabolic acidosis by getting a arterial blood gas and look at the pH of the blood. That's got to be less than 7.3. And there has to be evidence in the blood that he's burning fat. And there's a way to figure that out. And the lab can do that for you. He's got to show signs of osmotic diuresis, in other words, urinating a lot, and he was covered in feces and there was a strong odor of urine. His potassium's going to be out of whack. His potassium's going to be out of whack. And diabetic ketoacidosis is often triggered by an illness where they nest and get non-compliant with their disease and eat lots of comfort foods. Okay? The risk factors for diabetic ketoacidosis: infections in the body raise your blood glucose. Ignorance, what I mean here is not knowing how to manage your disease. It may be new to you and you really don't know how to manage it. So for a while, until you figured it out, you can end up with high blood sugars. Consuming alcohol increases your blood glucose in most patients, and that really depends on what the diabetic uses as their form of alcohol. If I'm drinking whiskey and water, probably not going to raise my blood glucose, probably is going to drop my blood glucose. If I'm drinking screwdrivers with lots of orange juice, that's probably going to raise my blood glucose. Implantation, we're talking about gestational diabetes. 10% of all pregnancies end with gestational diabetes. Ischemia, we're talking about heart attacks. And infarction, we're talking about heart attacks as well as kidney damage. Stress, illness, cause the blood sugar to rise in your body. Remember I had mentioned that your body kicks in stress hormones to help you fight the infection. So the body releases epinephrine, the body releases cortisol, and these things cause, along with glucagon, cause the liver to release sugar into your bloodstream and your blood glucose rises. Okay? And again, if you're sick and you don't feel well, that's where you want to skimp eat, or you want a quick fix, or you want to overeat, or you want to eat foods that are comforting. You get out of your routine and you end up with higher than normal blood sugars. If a person has chronic hyperglycemia, has high blood sugars all the time, they may develop this condition known as acanthosis nigricans. And with this condition, you get brown markings, particularly around the neck, and under the arms. And these brown markings are caused by high levels of circulating insulin. And remember, the more heavier you are, the more insulin your body has to produce. So this marking, or this sort of pattern on the skin, is often associated with obesity. So what are we going to do for this guy on the couch with a coma? We need to position him to protect his airway. We need to establish an IV, hook him up to a heart monitor. Doing a pulse oximetry certainly would confirm the need for oxygen. The fact that he's breathing deep and rapid is because he's trying to get rid of acids, not because he's short of breath or has a need for oxygen. We want to get that blood sugar reading. We want to give him fluid boluses, like 20 milliliters per kilogram of body weight. So a big old boy like me would get about 2 liters of fluid as a bolus. You want to monitor the heart rhythm, because with high blood glucose also comes potassium problems, which can affect the heart rate and the heart rhythm. You want to make sure that if not already done, the paramedics are on their way if you don't have the ability to establish an IV. The patient needs insulin, and if they're in diabetic ketoacidosis, they may need a slew of other medications until they can get some emergent dialysis. Here's another scenario. You're paged for a woman with slurred speech and who's leaning. And upon arrival, you're led to a bedroom where you find this woman sitting. She knows her name. Her speech is slurred. Her staff says, you know, she's a little more confused than normal. What would you like to know? Or how would you like to begin your assessment? It begins with, again, maybe asking questions of the staff, what her medical condition is, surveying the scene for clues as to what sort of medical problems she may have, getting a good set of vital signs. Her temperature is elevated a little bit, her heart rate's up, her respiratory rate's up, her blood pressure, that might be normal for an elderly woman in an assisted care facility. You can ask the staff if it is. Her skin is pale, warm, and dry. We're going to do the AVPU. She's alert to her name, but she doesn't know who she is or where she is. Doesn't have a good idea of place and time. And again, you'd ask staff if that's normal for her. They told you initially that that wasn't normal for her. So you can go through your AEIOU tips to see if there's a common cause for her altered mental status and slurred speech. Continuing your assessment into your OPQRST and your sample, they do tell you that she is somewhat Alzheimer's, but this leaning is new. So it's not uncommon for her to forget where she is or time of day, but this leaning and the slurred speech, that's new. They noticed her problem with her walking when she got up the first time this morning. Nothing's changed since this morning. Her speech is slurred. It seems to be affecting her right side, and you know that this is, she's exhibiting signs of a stroke. Slurred speech, right-sided weakness. It's been going on about an hour now. She's had no history of stroke or diabetes, but all along we're thinking, at least I am, we might be dealing with a stroke here. Slurred speech, leaning to the right, but you note a really strong odor of urine. She has no allergies. She takes a lot of medications, anti-inflammatories, water pills, Synthroid. She has a past history of hypertension, hypothyroidism, Alzheimer's, CHF, and ulcers. She ate last night. She was attempting to get up for breakfast when they noticed the altered mental status and leaning to the right. They watched her and she didn't get any better, so they called family and then eventually called you. I'm still thinking stroke here, but because she has an altered mental status, I might get a blood glucose, and I see that it's 625. Well, if she's not been diagnosed with diabetes, she's going to get the diagnosis now. Or if she is diabetic, she has hyperglycemia. But I didn't notice any sweet, fruity odor. I didn't notice any really deep and rapid breathing. I just have all the classic signs and symptoms of hyperglycemia. So this type of hyperglycemia is more than likely caused by HHNC. She's got a really high blood glucose, but she's not metabolizing fat. Okay? She has hyperglycemic, hyperosmolar, non-ketonic coma. Gradual onset, frequent urination, dehydration, altered level of consciousness, tachycardia and low blood pressure. Blood sugars greater than 600, often in 1,000, 1,200. Ketosis doesn't occur. There's no fruity odor, no metabolic acidosis with this type of diabetic emergency. Treatment for her, same thing, position her so she doesn't aspirate, establish an IV, hook her up to a heart monitor, get a pulse oximetry to determine the need for oxygen, get a blood glucose reading, and she needs rehydrated as well, somewhere around 20 mils per kilo, and if not already, call for the P-assist. Patient needs insulin or maybe some oral medications. In summarizing the two, low blood sugar comes on sudden. They take their insulin but they don't eat, or they eat late, or they don't eat the right food. They exert themselves more than what they normally do. They look like they're in shock. They're pale, cool, sweaty, tachycardic, high blood pressure, bounding pulse, low blood sugar. Now, we know the treatment for these folks, certainly if they can swallow, is glucose paste or sugar of some kind. What we use is what's called the rule of 15. We give them their sugar, we check their blood glucose, and it should come up, and then we give them 15 grams of carbohydrates. And 15 grams of carbohydrates will help regulate their blood glucose at a more normal number rather than peak and trough. 15 grams of carbohydrates could be 2 crackers, a slice of bread. So oftentimes I know if you give a diabetic sugar and they become more responsive, you'll encourage them to eat something. Okay? With hyperglycemia, it's gradual. It doesn't come on suddenly. This is an undiagnosed diabetic or a diabetic who's not taken their insulin, or a diabetic who is stressed or ill. Because with hyperglycemia, they get that osmotic diuresis. They're going to develop the polyps. They're going to be thirsty and hungry, and they're going to be making lots of urine. So they're going to be dehydrated. Their skin is going to be dry and warm and tint when you pinch it. They may have abdominal cramping. They're going to have rapid heart rate, low blood pressure. If they're burning fat, their breathing is going to be very deep and rapid. Their breath is going to have a fruity odor, and their blood glucose is going to be high. treatment for this, as we've already discussed, is fluid and insulin, and then maybe some potassium in the hospital. Now, there are a variety of ways that people are managing their diabetes. If we look at type 2 diabetics, 58% of type 2 diabetics manage their diabetes with oral medication alone. 16% don't use anything. 12% manage their diabetes with insulin only. And 14% have that diabetes 1.5. They manage their type 2 diabetes, or type 1.5, with insulin and medications. So there are non-pharmacologic therapies, diet and exercise. There are oral meds that you can take. There are non-insulin injectables that you can take, and there are insulins. So non-pharmacological medical therapy, in other words, we're not going to take any medicines. We're going to try to optimize our blood glucose. We're going to improve our blood lipids or lower our triglycerides by diet and exercise. Consistent carbohydrate intake. 45% of your diet is carbs. Modify your fat and calorie content. Space your meals out evenly so you get a nice level glycemic spike. Increase your physical activity. Lose at least 10% of your body weight. And these things alone may measure or may treat your type 2 diabetes. There's a variety of medications out there that people take to manage their diabetes, type 2 diabetes. There's metformin, which is by far the most common type of medicine that a type 2 diabetic will take. There are sulfonylureas, like glipizide. There's Actose, Prandin, Miglitol. And then there are injectables that act like glucagon in helping raise your blood sugar. Byetta and Januvia and Victoza. Now, these medications lower your blood sugar. This is metformin. They lower your blood sugar because your liver decreases sugar production when you take these drugs. And these cause an increase in sugar absorption into your muscle cells. By doing that, you decrease the body's need for insulin. And because the pancreas doesn't produce more insulin, you actually lose weight when you take this medication. And metformin is the only drug of this type that's available anymore. The sulfonylureas stimulate the cells in the pancreas to make more insulin. That helps your insulin work more effectively. It does cause weight gain, so it's not really suited for people who are overweight. It can be taken once or twice a day or shortly before a meal, and glipizide is the most common type of this drug. Actose, or these drugs up here, lower insulin resistance in muscle and fat, and they reduce glucose production by the liver. These drugs work quickly and they don't stay in the body long, so they have to be taken just prior to eating a meal. It stimulates the beta cells to hammer out more insulin and helps your body better process your sugar and lower your blood glucose levels. And finally, these medications prevent the digestion of carbohydrates. If I don't break carbohydrates down to simple sugar, I don't raise my blood glucose. And they include those. These drugs are new on the market. These are injectables. They're non-insulin injectables that come in injectable pens. Victoza increases insulin secretion, it delays gastric emptying, and it suppresses glucagon secretion. So these things all help lower your blood sugar. Byetta is made from the saliva of a Gila monster, and Byetta lowers the blood glucose as well. Now, if oral medications or those two new injectable medications don't work to help lower your blood glucose, you may have to take insulin, or type 1 diabetics take insulin. Now, the type of insulin that they take depends on when they want it to work, or when they need it to work the hardest, or how long it lasts. And many of the insulins today come in injectable pens so that you don't have to carry needles and syringes. There's a variety of insulins out there, and what this chart illustrates for you is regular insulin, NPH, Lantus. These tell you how fast they work and how long they last. So things like Humalog and Novolog, 10 to 15 minute onset, they peak at about an hour and a half, and they last about 4 to 5 hours in helping lower your blood sugar. Regular takes a little longer to work, peaks a little longer, and stays in your system longer. NPH, again, longer. When we get to Lantus, Lantus takes a while to work. It doesn't peak, and it lasts about 24 hours. So you'll see folks that maybe take metformin and aren't lowering their blood glucose enough, so they'll take Lantus at night or Lantus in the morning, inject it so that over the period of the entire day it slowly helps lower your blood sugar. Insulin pumps are available now for diabetics. Typically, you've got to have 3 to 6 months of regular insulin injectable therapy to be considered for a pump. You have to be able to test your blood glucose at least 4 times a day. You have to have the ability to problem solve and adjust the insulin that's being delivered into your fat tissue in your stomach. You have to be able to check the pump out. Once you're given a pump, they let you trial it. A certified pump trainer will work with you on a saline trial to make sure that you don't have any difficulties or problems, because if you do, you could adjust this improperly and give yourself way too much insulin and drop your blood sugar really low. Okay? And this certified trainer will work with you until you go live with the pump on yourself, and then there'll be some daily follow-up, looking at your blood glucose levels at different times of the day, counting your carbs, seeing how much insulin that you're giving yourself and what type of insulin. People on pumps, it's more of a long-term sort of thing, long-acting sort of insulin. So depending on what they eat, they may still have to give themselves an injection of insulin that works really fast to cover what they're eating. Insulin pumps are put on through infusion sets. They can be placed in the abdomen, the back hip, the leg, the arm. There's a 90 degree, there's an angle degree, there's a metal infusion set. You know, some of the issues are selecting the site. Often depends on how active you are. Cannulas can become bent, they can become occluded, and then you wouldn't be getting any insulin at all. If, as a diabetic, I really want to know how do I care for my disease, then this is one thing that we can look at. As a diabetic, I want to keep my A1C under 6.5. If I can do that, if I can keep my A1C under 6.5, that tells me that my average blood glucose over a 3-month period, my average high is 135. So that's good. That's good. I want to keep my blood pressure less than 130/80, because chronic hypertension with diabetes is the #1 cause of kidney failure. I want to keep my cholesterol. I want to keep my low-density lipoids, or my bad cholesterol, less than 100. And I want to keep my happy density lipoids, or my high-density lipoids, my good cholesterol, above 40 in men and above 50 in women. I want to keep my triglycerides less than 150. Triglycerides, that's that free liquidy fat that kind of floats around in the system and plugs stuff up. I want to keep that less than 150. And those cholesterols can all be managed with diet, exercise, and if necessary, statins to help lower blood cholesterol. So what does the future hold for us? They're looking at oral and inhaled insulins. Boy, if a person could take an insulin orally, or if they could inhale an insulin through their nose, no more shots. That'd be awesome. Insulin patches, where they just put a patch on their body and the insulin is slowly absorbed, much like a nicotine patch or an estrogen patch. Implantable insulin pumps, so that they can be more active and it can more, act more like the pancreas. No stick glucometers. This technology is close. It's very similar to the technology of measuring blood alcohol. When you breathe into a device that can measure the amount of alcohol in your blood, they're so close to having devices that you can breathe into and it measures the amount of ketones in your breath. So it would measure or estimate your blood sugar as a result of ketones in your breath, that's not far off. No stick glucometers. Transplants. I have friends that have had pancreas transplants, islet cell transplants in their pancreas, so that they no longer need insulin and they regulate their blood glucose like everybody else. And of course, the future always holds the potential for a cure. So in summary, we are what we eat. Sugar and high fructose corn syrup are causing major health risk crises in the United States. We know that sugar in moderation is needed. You got to have sugar to make energy. 6 to 9 teaspoons a day. Remember that 4 grams equals 1 teaspoon when you're measuring it. Remember also that 100% of all carbohydrates are eventually converted into sugar. So you want to have about 45 grams of carbohydrates a day. And that requires you looking at the label on your food that you're eating, and that's why it's labeled, so that you can see how many carbs that you're taking in with that food. We know that diabetes is a disease that evolves around sugar, and that hyperglycemia can lead to serious health problems, long-term health problems, kidney failure, heart attack, stroke, liver failure. Any questions? We'll open this up now, give you an opportunity to ask any questions that you might have. I'd ask that you open your mic and ask the question. And if there are not, that's all I have for you tonight.
Yes. If a patient has been stated to be 90 with 0.3 IOB, what does the IOB stand for?
They're stated to be what?
That their level is a 90 with a 0.3 IOB. What does the IOB stand for?
You mean when you measure their blood glucose, or they've had their blood glucose taken and they've been told it's 90 with an IOB of point something?
Yes.
I'm not certain. I would have to look that up. And what I'll do is I'll look that up for you, and I'll get that information back to Cherry. I've never heard of that, so I'm not sure what they're referring to. Any other questions? If not, I want to thank you all very much for your attention this evening, and I really appreciate the opportunity to talk to you tonight about diabetes. You can sign off if you're done.
Thanks, Jeff.
Thanks.
Thanks, Jeff.